Hello, everybody. Thank you all for attending. It gives me great pleasure to introduce our grand round speaker, Dr. Ruchika Bhargav. Ruchika is one of her own. She's a New Jerseyan. She did her undergrad at Rutgers, and she went to Rowan University School of Osteopathic Medicine, following which she went to Albert Einstein. She actually was a chief fellow there at Albert Einstein Medical Center. And then we were lucky to recruit her to Rutgers. She's one of our non-invasive cardiologists. In addition to actually just plain old research that she has been doing in various aspects of cardiology, Ruchika also has done a lot of service to community as well, which is really compelling and interesting. She has published a lot. She's got multiple peer-reviewed abstracts under her belt. The community service that actually was interesting is when she did blood pressure checks, glucose checks, and cholesterol screenings, along with stroke risk assessment. So her eye is absolutely toward prevention as well. Ever since she joined cardiology here, she has been spending a lot of time learning about hypertrophic cardiomyopathy as well as cardiac amyloidosis. She has been working closely with both myself as well as Dr. Bokhari, and she has a great interest in hypertrophic cardiomyopathy. She's going to be talking to us about obviously hypertrophic cardiomyopathy, but the title is Unraveling the Thick Heart. So this is going to be phenomenal. She's going to help us do a deep dive into the contemporary management of hypertrophic cardiomyopathy. So I'm going to, before we start the grand round session, I'm just going to share my screen because I know all of us need to remember and do the mock points and the CME credits. So I'm going to share my screen. So obviously everything we do, all the grand rounds are on YouTube. So here is the link on the YouTube in case you want to go back and listen to Ruchika's talk, but also the previous grand rounds talks as well. Then I actually have a couple of steps to be able to obtain CME credit. So text 25662 to the number 888-816-4893 within the next 12 hours. You text as an SMS message. And this will be in the chat that Andrea will put in as well. And for the mock points for physicians, not only do you complete the CME credit information, but also answer a brief quiz. And please remember the room code, it is Future 2024. So these will be in the chat box as well. So with this, I'm going to switch gears and Ruchika, please go ahead and teach us.
Good evening, everyone, and thank you, Dr. Magandhi, for the introduction. I will share my screen. Can you see my screen in presenter mode now?
Now, yes.
Now, yes? Okay, all right. Good evening, everyone. So I'll be presenting on hypertrophic cardiomyopathy today, given my personal interest in infiltrative disease. And my goal for today is to provide a brief overview on the contemporary management of hypertrophic cardiomyopathy. As a lot of you might know, recently we had updated guidelines on HCM that came out about 5 to 6 months ago. So I will be presenting the pertinent recommendations from those guidelines in today's talk. And the goal is to explain the pathophysiology of HCM, most importantly, to understand, how to perform appropriate risk stratification for these patients for sudden cardiac death, and also go over the pharmacological and invasive treatment options in terms of management. So when a lot of us think about HCM, I think one of the first things that comes to mind is, a young athlete suddenly collapsing on the field. Unfortunately, some of them pass away, and a diagnosis of HCM is made after they've passed away. This is a figure that basically looks at causes of sudden cardiac death in competitive athletes. And as you can see, there's a variety of congenital, genetic, acquired abnormalities that are responsible for these events. But really, HCM is the single most common cause, accounting for about 1/3 of these cases, according to the US registry data. And this figure on the right here describes the global prevalence of HCM. The darker areas represent countries with, patients with HCM. And the estimated prevalence, at least up until 2017, was about 15 to 20 million patients who were affected worldwide. So just some historical perspective, Henry Louisville in 1869, he was a French pathologist, and he was credited for describing the first case of HCM, which was believed to be a case of a patient who had left ventricular outflow tract obstruction. In 1958, Robert Taylor, he published a series of 8 autopsy cases that were noticed to have asymmetric hypertrophy or muscular hamartomas of the heart. By 1961, the disease was still poorly understood, but the one thing that was clear was that this disease is distinct from aortic stenosis. And it was termed idiopathic hypertrophic subaortic stenosis. As you kind of go down the timeline, you can see when different medications were introduced. You had alcohol septal ablation that was introduced in the mid-1990s. Myectomy had been present from about the 1960s, but it was pretty high risk at that point. After 2000, we started having guidelines that came out. So 2 things that are missing on this flow sheet. One is in 2022, mavacamten was approved by the FDA in terms of treatment for symptomatic obstructive HCM. And then, as I mentioned, in 2024, we had the most recent update to the HCM guidelines. This is just a picture of the first patient in the United States who was diagnosed with HCM, Mr. Claude Brady, along with Dr. Braunwald, who diagnosed him with this disease. And he was interestingly noted to have a heart murmur at age 11. And at that time, it was attributed to a family trait. He could date back to 4, generations of multiple family members who passed away at a young age. And he was eventually diagnosed with HCM. He underwent a heart transplant, and he passed away peacefully just about 2 years ago. So in terms of background, HCM was once considered a rare inherited cardiac disease. It was difficult to diagnose. We didn't really have good treatment options out there, but now it's recognized as a much more common disease worldwide. The general population prevalence is about 1 in 200 to 1 in 500. And there's no differences in distribution by gender. There have been some differences in prevalence that have been reported by race and ethnicity, but these likely reflect differences in underlying social determinants of health. And it's inherited in an autosomal dominant pattern. And, interestingly, in terms of, there's a number of clinical markers and testing strategies that you can use to differentiate HCM mimics from HCM. Of course, some of these mimics are glycogen lysosomal storage diseases, athlete's heart, longstanding hypertension, amyloidosis. I will be going over a lot of these markers later on in the talk. Just of note, briefly, to differentiate athlete's heart from HCM, findings that are more suggestive of HCM are LV wall thickness of more than 15 millimeters. If they have a small LV cavity size, they have diastolic dysfunction or systolic anterior motion of the mitral valve leaflet. In terms of definition, again, this disease is confined to the heart. So really you want to look for presence of, LVH, but in the absence of another cardiac, systemic, metabolic cause. You can diagnose this with 2D echo or cardiac MR. In adults, it's defined as an end diastolic maximal wall thickness of greater than or equal to 15 millimeters. Anywhere in the left ventricle, obviously in the absence of another cause of hypertrophy. Now, in children, the diagnostic criteria is confounded because you need to adjust for body size and growth. So we use a Z-score. A Z-score of more than 2.5 in a child with no family history is diagnostic, and a Z-score of more than 2 in a child with definitive family history or a positive genetic test is diagnostic. And again, in these patients, you can see any pattern and distribution of increased LV wall thickness. So in terms of the role of genetics, so it's been identified as a potentially monogenic disease, but recent data suggests that there is a potential polygenic susceptibility, that's implicated. Now, you can have 8 or more genes that encode the cardiac sarcomere that have been implicated. 30 to 60% of HCM patients actually have an identifiable pathogenic or likely pathogenic variant. However, there's actually still a good proportion of patients with HCM who do not have any evidence of genetic etiology, and they also have no other affected family members. So this is really termed the non-familial HCM distribution. And what these observations suggest is that, there's potentially other novel pathophysiologic mechanisms that might be responsible for the phenotypic expression in these patients. Now, both genetic heterogeneity, which is defined as distinct genes that cause the same disease, or allelic variation, which is distinct mutations in the same gene, can actually contribute to the morphological phenotypes and the disease severity. And of course, these complexities pose a significant challenge for us as clinicians because we have to interpret these genetic results and use this information to improve patient management. When we talk about genes, the 2 most common genes, which are present in about 50-60% of these patients, are beta-myosin heavy chain 7 and myosin binding protein C3. The other genes that are present, these are cardiac troponin I, cardiac troponin T, alpha-tropomyosin, myosin regulatory light chain, myosin essential light chain, and cardiac alpha-actin. They're present in up to less than 10% of the cases. And again, even though each offspring has a 50% chance of inheriting the variant from an affected family member, the age at which that disease expression occurs and the degree of expression is pretty variable. This is just a chart that really just kind of goes over the terms that might come up when these patients undergo genetic testing, pathogenic variants, likely pathogenic variant, and just some other terms. Again, really just the top 2 have a strong, they basically mean that there's a strong genetic evidence for their involvement in the pathogenesis of HCM. So coming to the pathogenesis, so there's 3 main histological features in these patients. 1 is myocyte hypertrophy, 2 is myocyte disarray, and 3 is myocardial fibrosis. Having said that, the exact biochemical and biophysical mechanisms are still not completely understood. But what we do know is that on panel A, on any normal heart at any given moment during diastole, there's really only a small fraction of the MYH7 molecules which are bound to the actin molecule. So there's about 50 to 60% of myosin molecules that are completely dissociated from actin, and they're in a super relaxed state. Now, when you have these genetic mutations, what happens is you basically have a shift from the super relaxed state to a strongly bound state of the actin and the myosin. They form these cross bridges. And these increased number of complexes lead to basically increased contractility and impaired relaxation in these patients, which then leads to a cascade of secondary events that cause histological, morphological, and the clinical phenotypes of HCM. One notable feature in these patients is that they have a hyperdynamic LVEF. And again, that's because of these increased number of actin-myosin complexes, even though they have a reduced regional myocardial strain and decreased tissue Doppler velocity. Increased calcium sensitivity of the myofilament is also a major determinant of cardiac systolic function. So when we think about pathophysiology, we want to consider dynamic LV outflow tract obstruction, mitral regurgitation, diastolic dysfunction, myocardial ischemia, arrhythmias, and metabolic and energetic abnormalities. Now, for a given patient with HCM, the clinical outcome might be dominated by one of these components, or it might actually be a result of complex interplay between these components. So when we think about LVOT obstruction, ECHO gives us pretty good estimates, quantitative estimates of the peak instantaneous LV outflow gradient, to characterize the mitral regurgitation, provide assessment of aortic mitral valve abnormalities. And for obstruction, the peak gradient has to be greater than or equal to 30 millimeters of mercury. And if that's defined as obstructive gradient, if it's less than that, we recommend provocative maneuvers. For it to be attributed to causing symptoms, the gradient should be greater than or equal to 50 millimeters of mercury. And it's important to keep in mind that the LVOT obstruction is dynamic, and it could be affected by changes in preload, afterload, or contractility. So the panels here, A and B, show at resting state, there's no SAM, there's no outflow tract obstruction. And panel C and D, you basically see this is a stress echo that was performed, and there's SAM, and then also you see the dagger shaped. And the gradient here was, given the velocity of approximately 5 meters per second, was about 100 millimeters of mercury. When we talk about diastolic dysfunction, so there's multiple factors that play a role. You can have altered ventricular load with high intracavitary pressures. Again, as we talked about, there's impaired relaxation, impaired LV compliance because of fibrosis, there's altered genetics, microvascular ischemia, and delayed inactivation from abnormal intracellular calcium uptake. So you can have small LV cavity size. We have seen restrictive physiology in these patients from the severe hypertrophy. And all of this leads to exertional dyspnea, fatigue. They have reduced exercise capacity. And these by itself, the diastolic dysfunction by itself is an independent marker of adverse prognosis. So these patients, given their abnormal physiology, really highly rely on atrial systole for ventricular filling. And as you can imagine, they poorly tolerate arrhythmias such as atrial fibrillation when you get the loss of atrial clip. In terms of SAM, it could be because of, the mitral regurgitation could be because of systolic anterior motion or primary mitral valve apparatus abnormalities, which could just be, a long leaflet, anomalous papillary muscle insertion, anteriorly displaced papillary muscles. If the MR is because of SAM, you typically get mid to late systole. It's typically directed posteriorly or laterally. Now, you could have anteriorly or central or anteriorly directed jets from SAM, but typically they're posterior. So if you do happen to see an anteriorly directed jet, you want to think about abnormalities in the mitral valve apparatus. And if you're planning for invasive septal reduction therapy, it's important to closely examine the mitral valve to determine the optimal invasive approach. So when we think about myocardial ischemia, these patients have potential mismatch between myocardial action supply and demand. They frequently have microvascular dysfunction with impaired coronary flow reserve. They have myocardial hypertrophy, medial hypertrophy. So in terms of diagnosis, it's important to have a comprehensive medical history, thorough physical exam, but also a 3-generation family history. When we see them in our HCM clinic, a lot of times they were referred because they might have had a cardiac murmur that was picked up by a PCP. They underwent an echo, which showed increased LV wall thickness, and then they were, underwent a cardiac MRI, and then they were referred to our clinic. Many might have a harsh crescendo, decrescendo systolic murmur because of LV outflow tract obstruction. They might have a fourth heart sound. And in terms of symptoms, the 2 big symptoms you really want to consider in these patients are exertional dyspnea and fatigue. I mean, of course, they can have chest pain, palpitations, lightheadedness, lower extremity edema. But really, these two, they're seen more often in patients who have significant LVOT obstruction. So in terms of diagnosis, TTE is recommended in terms of the initial evaluation. So in patients who have been diagnosed with HCM, the guidelines recommend that you repeat a TTE every 1 to 2 years. And this is more so to assess the degree of hypertrophy, the LV outflow tract obstruction, mitral regurgitation, the presence and severity, and myocardial function. In our HCM clinic, we basically repeat a TTE every year for these patients, sooner if there's a change in clinical status. And if they have a resting gradient, peak gradient that's less than 50, you should consider provocative maneuvers. Now, in individuals who have their genotype positive, but they're phenotype negative, you should just do an echocardiogram at periodic intervals. So in children and adolescents, that's every 1 to 2 years. We recommend yearly in our clinic, and 3 to 5 years for adults. And of course, if they have a change in clinical status. TE can be useful in these patients if there's uncertainty regarding the mitral valve, structural abnormalities, or you're not sure about the mechanism of mitral regurgitation, or you think there might be another cause for outflow obstruction, such as like valvular stenosis. So CMR, in patients, if the TT is inconclusive, you can consider CMR imaging for diagnostic clarification. It can really help identify focal areas of LVH, especially when the hypertrophy is confined to certain regions of the LV, including the anterolateral wall, the posterior septum, and the apex. So this increased sensitivity, in CMR is because of the high spatial resolution, and also, you're not really hindered by poor acoustic windows, which could be the case in TTE. Again, if you're not sure about their stratification for sudden cardiac death, and you're not sure if you should really proceed with an ICD or not, a CMR can be useful because you can accurately assess the maximal LV wall thickness. You can assess for presence of LV apical aneurysm, look at LVEF, and then also get a better understanding of the extent of late gadolinium enhancement in these patients. Now, in terms of continued risk stratification for patients, who don't have an ICD yet, the guidelines recommend you can consider contrast enhanced CMR, again, to assess the same things we discussed here, every 3 to 5 years. And this is what we recommend in the clinic too. If it's a younger patient who has more red flags, we tend to maybe repeat it every 3 years, if not every 4 to 5 years. So I'm just going to let this clip play. So these are images and a clip from one of our HCM clinic patients. Unfortunately, this is a 32-year-old male. So he had a history of hypertension. He was seen by one of our general cardiologists. He underwent a TTE. The TTE shows severely increased LV wall thickness. So he then subsequently had a cardiac MRI. So I hope you can appreciate here on the apical 4-chamber view that he has pretty impressive apical hypertrophic cardiomyopathy. The apical septum measured about 21 millimeters. The EF is normal. And more importantly, on the right-hand side, you can see the patchy LGE that's present in the mid to apical segments. So his total percentage was quantified as more than 25%, which, as I'll describe later in the talk, is pretty significant. So these are clips from a different patient in our HCM clinic. So these are apical 2 and 3 chamber views, and what I wanted to highlight here is the apical aneurysm with the associated hypertrophy. So this is a 71-year-old female who basically was noted to have an apical aneurysm with apical dyskinesis and SAM. The introseptal wall measured 21 millimeters, and the EF was 56%. So in terms of the 12-lead ECG, obviously that's recommended as part of initial evaluation, and you should also consider ambulatory ECG monitoring. The guidelines recommend 24 to 48 hours. We do about 2 weeks in our clinic. In terms of invasive angiography, so if you have uncertainty regarding the presence or severity of the LV outflow obstruction on non-invasive studies, you can consider cardiac catheterization with invasive hemodynamic assessment. Now, they can perform several provocative maneuvers in the cath lab to identify the presence of a latent gradient, including Valsalva maneuver or induce a PVC to assess for Braunwald-Marrow sign, which basically represents a post-PVC induced augmentation in the LVOT gradient and a reduction in the aortic pulse pressure. And of course, if they have symptoms or evidence of myocardial ischemia, or if they're going to be undergoing surgical myectomy and they're at risk for coronary atherosclerosis, then you would consider a cardiac catheterization. So exercise stress testing. Stress echo really represents the most physiologic form of provocation for these patients to identify the presence or severity of LV outflow tract obstruction, especially if it's less than or equal to 50 on resting TTE. In patients with non-obstructive HCM and advanced heart failure, they recommend performing cardiopulmonary exercise stress testing. And in pediatric patients with HCM, you really should consider exercise stress testing to determine functional capacity as long as they can comply with exercise stress testing protocol. The guidelines also recommend for asymptomatic patients with HCM who do not have a resting gradient greater or equal to 50, you should still consider an exercise echo, and that just really helps classify the disease severity in these patients and helps guide future management, in terms of if they do have presence obstructive physiology on the exercise stress echo. So genetic testing is really helpful more so for the family members, to identify family members at risk for developing HCM. We don't have a dedicated genetic counseling department here, but it would be something nice to consider down the road because a genetic counselor really should be on board. And first-degree relatives, you should do ECG and 2D echo screening. And in patients with HCM who've undergone genetic testing, and they have, so the guidelines interestingly recommend that you should have serial reevaluation of the clinical significance of the variant to maybe see if the variant has been reclassified, because the genomic database keeps getting updated and constantly keeps getting evolved. It's constantly evolving, and so variants can be upgraded or downgraded. So especially for patients, if they have a variant of undetermined significance, the guidelines recommend, they don't really tell us how often, but maybe every couple of years or so, you should consider reevaluation of the clinical significance of the variant. And for patients with HCM who have no pathogenic variant, the guidelines say you really should not perform cascade genetic testing. So I talked about the 8 sarcomere genes. They identify a disease-causing variant in about 30% of sporadic cases. The prenatal genetic counseling can also help in discussing potential reproductive options for these patients, especially if they're considering IVF. This is a table that I took from the guidelines that basically goes over the annual screening for these patients, which, again, as I mentioned, is pretty much annually for children and every 3 to 5 years for adults. This is a schematic. Again, it's taken from the guidelines. I kind of went over this, but briefly, if you do genetic testing, if they have a pathogenic variant and the family member tests negative, then you really don't need further clinical genetic testing. But if it's just likely benign variant, then you want to consider clinical surveillance. So let me just go back. So sudden cardiac death in these patients, if they have a personal history of cardiac arrest or sustained ventricular arrhythmias, if they have a personal history of syncope, especially within the last 6 months, or if they have a family member with HCM-related sudden death, or they have a maximal LV wall thickness, LV apical aneurysm, NSVT episodes, these are considered risk factors for sudden cardiac death. This table is very important. It kind of highlights the exact definitions for these risk factors in cardiac death. So for family members, if the HCM is in one or more first-degree relative who is younger than 50 years of age, if they have massive LVH and the wall thickness is greater than or equal to 30 millimeters, that's a risk factor. If they have unexplained syncope, systolic dysfunction, EF less than 50%. If they have LV apical aneurysm or extensive LGE, the number to remember for this is if it's greater than or equal to 15% of the LV mass, that's a risk factor for sudden cardiac death. And in terms of ambulatory ECG monitoring for NSVT, we really look at longer, frequent, and faster runs. So if the run is fast enough, is greater than or equal to 200 beats per minute. If it's longer, 10 or more beats, these are considered risk factors. So when we do annual monitoring in our HCM clinics, these are numbers that we take a look at. And of course, if they have a genotype positive status associated with a higher sudden cardiac death risk in pediatric patients with HCM. So when we talk about ICD placement, it's important to keep in mind that younger patients are at higher risk for sudden cardiac death than older patients. And there really appear to be no sex or race-based differences in these patients. Shared decision-making is the key. You need to have a thorough and balanced discussion with these patients about the evidence, the benefits, and risks of ICD. So if someone's had a cardiac arrest or sustained VT, of course, they should get an ICD. And if patients who have been diagnosed with HCM, but they have one or more major risk factors for sudden cardiac death, it's reasonable to offer an ICD. This is the class of level of evidence 2A. And these are the risk factors that I kind of went over, which is basically family history. Just remember the number is greater than or equal to 30 millimeters. Syncope, especially within the last 6 months, that was not neurocardiogenic. Presence of LV apical aneurysm or extensive LGE greater than or equal to 15%, or LV systolic dysfunction of less than 50%. EF of less than 50% in HCM patients is roughly about the same as someone who might, let's say, have significant HFrEF, but who does not have HCM. So this is a table. So AHA has a 5-year sudden cardiac death risk calculator. This is just a screenshot. It doesn't really cover the whole calculator, but this is something also that you can use as an additional tool when you're performing shared decision-making with the patient. And in terms of device considerations, so patients with HCM who receive ICDs, they are usually younger than those with ischemic and even non-ischemic cardiomyopathy. So they have lifelong complications that are likely higher than patients who do not have HCM. And the complications of ICDs may be higher in kids and adolescents because of higher baseline heart rates. That can lead to inappropriate shocks, somatic growth that increases the risk of lead fracture, and the need for multiple, device replacements over the lifetime. So the guidelines recommend a single chamber transvenous ICD or a subcutaneous ICD after shared decision making. In selected adult patients who have non-obstructive HCM and they are NYHA class 2 to 4, and they have a left bundle branch block with an EF of less than 50%, it's actually a level of evidence 2A to consider CRT therapy for these patients for symptom reduction. So in terms of advantages and disadvantages in HCM patients for transvenous device and subcutaneous ICD, so obviously for transvenous, you can pace for bradycardia, you can have anti-tachycardia pacing for VT. It's smaller size, you have extended battery longevity. Disadvantages are that the lead may fail over time, so that you would need additional leads to be placed, and the removal of older leads that has higher risks, and again, potential for lead infections. With a subcutaneous ICD, on the other hand, you have lack of a transvenous lead, there's fewer lead failures, and there's ease of removal. The disadvantages are that there's a larger size of the device, that you have this potential for increased inappropriate shocks and the inability to pace. So when we talk about management, I just wanted to highlight this figure because it's taken from the JACC state-of-the-art review on management of HCM, and just to kind of point your attention to the bottommost bar. So these basically represent chronic diseases, in the United States. And as you can see, HCM, the annual mortality is 0.5% per year. It used to be up to 8 to 10%. And the 5-year mortality is 2.5%. So really effective management strategies for major HCM complications have emerged, which have really improved the clinical course and substantially lowered morbidity and mortality with a good quality of life for these patients. And these patients can live, up to 70s and 90s. In fact, we have 2 patients on the consult service now who are in the mid 70s to early 80s. So it's pretty impressive, the advances that have occurred in this field. When we talk about pharmacological management, in patients who have obstructive symptomatic HCM, we start off with non-invasive dilating beta blockers. These should be titrated to maximal doses as tolerated. If these are not effective, you can consider non-dihydropyridine calcium channel blockers, verapamil or diltiazem. If patients still have persistent symptoms despite adding these medications, then for the first time in HCM guidelines, it's a class 1 level of evidence that they recommend myosin inhibitors in adult patients only. So that's pretty interesting. And disopyramide, of course, if you use that, you have to combine it with an AV nodal blocking agent because this medication can enhance conduction through the AV node. So if someone were to go into AFib, you would have rapid conduction with the onset of AFib. So they really should be used in combination for disopyramide, another AV nodal blocking agent. Now, it's important to keep in mind that patients with obstructive HCM, if they are acutely hypotensive, they're not responding to fluids, the vasoconstrictor of choice is phenylephrine because it's not going to have increased inotropic activity. So if they still have persistent left high-sided filling pressures, you can consider low-dose oral diuretics. And you want to consider discontinuation of ACE inhibitors, ARBs, negative inotropic, vasodilators, negative inotropic agents for these patients that can worsen symptoms by dynamic LVOT obstruction. And for patients with obstructive HCM who have very high resting gradients of more than 500, as well as children less than 6 weeks of age, verapamil is potentially harmful. Okay, so mavacamten, like I mentioned, it's been recommended for the first time in guidelines, and this is the cardiac myosin inhibitor. It's been shown to improve LVOT gradients, symptoms, and functional capacity, and it's available in doses of 2.5, 5, 10, and 15. So with these, with mavacamten, as we talked about the pathogenesis, remember that these patients with HCM who have obstructive physiology have increased actin myosin cross bridges. So mavacamten will decrease the number of excess bridges, and that will lead to decreased dynamic LVOT obstruction, improve cardiac filling pressures, improve energy consumption, and reduce cardiac contractility in these patients. Now, because of the risk of decreased systolic dysfunction, it's only available through a REMS program. And that's basically a risk evaluation mitigation strategy. So you need to have periodic echo assessment of LVEF before and during treatment with mavacamten. It's not recommended in patients who have an LVEF of less than 55%. And if the EF is noted to be less than 50%, you should stop mavacamten. In terms of echo monitoring, you should do it before the treatment starts, at 1 month, 2 months, 3 months, and then every 3 months thereafter. So I wanted to describe a patient case. Again, this is one of our HCM clinic patients. 80-year-old female with hypertension melanoma. She was NYHA class 2. She had NYHA class 2 symptoms and complained of severe exertional dyspnea. She had no family history of sudden cardiac death, and she was pretty symptomatic on high-dose calcium channel blockers. We discussed, different treatment strategies for HCM. She chose to go with she chose to be started on mavacamten. So I'm just going to let this echo play. This is pre-mavacamten echo. So here you can see severe basal septal hypertrophy, and she also has SAM, which you can see here. She also had at least moderate MR, and her EF is normal. Her resting gradient, which I'll show another slide, is 90 at rest, and then with Valsalva, it was 101. And again, this is pre-mavacamten, and she was started on mavacamten. This is her echo post. And you can still see some hypertrophy. And these are gradients. So this is the 2-month post-echo follow-up. At 1 month, the rest gradient was 16, the provoked was 25, and this is at 2 months, the rest is 11, and the provoked is 13. So a pretty significant difference post-mavacamten in just about 2 months. And in terms of symptoms, she denied any active cardiac complaints at the most recent clinic visit. So this is just one slide on another drug that's out there, aficamten, for symptomatic obstructive HCM. This is also an allosteric modulator, cardiac myosin inhibitor. And this was a Sequoia trial that basically found similar findings in terms of symptomatic improvement, gradient reduction, and improvement in NYHA functional class status for symptomatic obstructive HCM patients. Okay. So in terms of invasive treatment, septal reduction therapy is recommended if patients still remain symptomatic. In terms of symptomatic patients, if they have associated cardiac disease that requires surgery for another reason, such as they have anomalous papillary muscles, they have markedly elongated anterior mitral valve leaflet, intrinsic mitral valve disease, valvular stenosis, they recommend performing surgical myectomy. An important thing to keep in mind is that these procedures, they have high success rates, but again, these are done in experienced HCM centers. There's a lot of data that's coming out now that when these procedures, we talk about high complications, but it's really when they're not done at highly experienced HCM centers. Now, if the patient has contraindications for surgery, they have an unacceptable risk, they have advanced age, they are not amenable to undergoing open heart surgery, then that's when alcohol septal ablation is pursued. Again, that should also be performed at experienced HCM centers. For patients with HCM who are asymptomatic and they have normal exercise capacity, you do not perform septal reduction treatment, and you should not be performing mitral valve replacement just for the sole purpose of relieving LV outflow tract obstruction in these patients. So surgical myectomy. So as I mentioned, this mortality rate of less than 1% and this really high success rate is at experienced centers. The rate of complete heart block needing permanent pacemakers happens in about 1 to 5% of patients. And myectomy, it really leads to immediate and permanent elimination of outflow obstruction. So it relieves obstruction by enlarging the LVOT outflow tract cross-sectional area, and it redirects the flow away from the anteriorly positioned mitral valve, which again gets rid of SAM and subsequent mitral regurgitation. So the classic procedure, the Mara procedure, has now been has advanced, and now they actually do extended septal excision that goes well beyond the mitral septal contact point, involves the mid-ventricular septum to the level of the papillary muscles. And it improves heart failure symptoms and NYHA functional class and the quality of life in these patients. Again, typically transaortic, but you can do a combination of transapical and transaortic if they have complex mid-ventricular anatomy. So this is another case from our clinic. So the one on the left is pre-myectomy. So this was a 69-year-old female with diabetes, hypertension, fatty liver. She was seen over a year ago in our clinic initially. She had severe exertional dyspnea and fatigue, and she was NYHA class 3. So this echo here on the left, I hope you can see basically the severely increased LV wall thickness. EF is normal. The provoked gradient was 173. She was provided the options for, all the treatment options at HCM. She decided to pursue myectomy. And I'm going to let this one play. So up here, you can appreciate the post-surgical changes. Post-myectomy, she underwent left ventricular septal and apical myectomy in Mayo Clinic for mid-ventricular obstruction. And that was about a year ago, end of last year. And this echo was done 2 months post that at our institution, where her provoked gradient was 5, as compared to 173 pre-myectomy. But the most impressive thing was not the numbers that she had on echo. When I saw her in clinic, she told me, during this stage pre-myectomy, she would stop 5 times while coming from the garage to the clinic, and now she walks 2 miles daily, and she feels like a completely different person post-myectomy. So it's really amazing just to see them, to see such drastic transformation pre and post-myectomy, not just on echo, but also clinically. Alcohol septal ablation. So the advantages are brief hospital stay, rapid recovery, you avoid sternotomy and cardiopulmonary bypass. Now, compared to myectomy, there are certain higher complications. The rate of complete heart block is 10 to 15% versus less than 5% in patients with, who undergo surgical myectomy. They have slower reduction in gradient. So just remember, myectomy was immediate, almost permanent for most patients. Here, this takes about months. Some of them might need repeat ablations, 15 to 20%. And because of the alcohol-induced septal scar, you might have ventricular tachyarrhythmias. It's important to know that, when patients undergo myectomy, that muscular resection actually it's not associated with intramyocardial scarring. So they don't really get these excessive ventricular tachyarrhythmias, because of scar formation, and should not be considered in children and young adults or patients requiring valve repair or replacement, CABG, or, surgery for another indication. So this schematic kind of goes over some of the basic steps. So basically panel 1, that shows the coronary angiogram. You can see the arrow pointing here. So it's identifying the appropriate septal artery for ablation. Panel 2 here, it shows guide wire placement into the septal artery. Then panel 3 here, it basically shows balloon occlusion of the septal artery, and then you're doing selective angiography to make sure there's no reflux into the LED. At this time, you also get simultaneous echo to ensure that you have the appropriate basal septal location, the correct amount of myocardium is targeted. And then panel 4 here, this is after it's after the procedure, is the completion coronary angiogram. And as you can see, there's successful ablation right here of the septal branch. So this leads to immediate akinesia and then eventual scarring and thinning of the targeted septum, which then widens the LV outflow tract diameter, alleviates the LVOT obstruction over time, which takes months in alcohol septal ablation, as compared to immediate widening of the LV outflow tract diameter in patients who undergo surgical myectomy. So here, this is the myocardial contrast echo that's actually done real time, and that was for the case I just showed earlier, intraprocedurally. So the basal septum right here, which is where the arrows are highlighting, it's focally contrasted. There's direct contrast injection into the septal artery after balloon inflation. So this allows for us to basically make sure the mid-ventricular septum is not affected during the ablation, and to, again, just make sure the correct area is targeted. So when we look at non-obstructive HCM, patients with preserved EF, so non-obstructive HCM is pretty common, but there's a small percentage of patients that kind of go on to have advanced heart failure. In terms of management for non-obstructive HCM, so these patients, if they have symptoms of exertional angina or dyspnea, beta blockers or non-dihydroprotein calcium channel blockers are recommended, but if they're asymptomatic, the role of these agents is really not well established. It is reasonable to add oral diuretics if they still have exertional dyspnea. So in patients with advanced heart failure, so like I mentioned, LVEF of less than 50% is significant in patients with HCM, and you should initiate them on GDMT. In patients with non-obstructive HCM advanced heart failure, again, you should perform a cardiopulmonary exercise testing to quantify the degree of functional limitation, and again, to assist with heart transplantation assessment. If they have an EF of less than 50%, you should discontinue the negative inotropic agents, and ICD can be beneficial, and that's something we've discussed in the earlier slides, as well as the use of CRT in these patients. So what about atrial fibrillation? The one thing I want us to highlight is in HCM patients, if you have clinical evidence of atrial fibrillation, then regardless of the CHA2DS2-VASc score, they should be anticoagulated. DOACs are the first line, and Coumadin is the second line option. Now, in patients with HCM but subclinical atrial fibrillation, the data is not as clear. The guidelines say if it's more than 24 hours of duration, then they should be on anticoagulation. But when it's less than that, if it's more than 5 minutes to less than 24 hours duration for a given episode, they say that you can still consider anticoagulation in these patients depending on the total atrial fibrillation burden, the underlying risk factors, and the bleeding risk. In terms of rate control strategies, beta blockers, verapamil, diltiazem are options that you can take a look at. If they can't tolerate rate control, again, they poorly tolerate atrial fibrillation, rhythm control strategies for cardioversion or antiarrhythmic drugs. So catheter ablation can be effective, and all of the above is not. And in patients with HCM and AFib who need surgical myectomy, it actually is pretty beneficial if you want to consider concomitant surgical AFib ablation for these patients. So this is the table that I took from the guidelines. So class 1C agents are typically not recommended in patients with structural heart disease, which also includes HCM. But again, so the guidelines recommend that you really should not use these agents in the absence of an ICD. Disopyramide is here. You want to watch out for anticoagulation effects in these patients if you do happen to use it. Amiodarone, dofetilide,
I just think that's contrast.
Are also options. Okay. So management of ventricular arrhythmias. So if they're poorly tolerated, they are refractory to maximal medical therapy, and ablation, then heart transplant assessment is what's required. Now, physical activity and competitive sports, I think this is always a gray area. The guidelines do give you recommendations. I think that it should still be a shared decision-making process, and it really should be decided on a case-by-case basis, depending on the patient's risk factors, for sudden cardiac death, and the family history, and the genotype status. But regardless, the guidelines recommend mild to moderate intensity recreational exercise is beneficial in patients with HCM. In fact, they tell us that we should refrain from universal restriction from vigorous physical activity in these patients. Now, in patients who are genotype positive, so they had a positive genetic test, but they're phenotype negative, so they've not had clinical manifestations of HCM, the guidelines recommend that these patients could participate in competitive sports of any intensity. But again, I think that should be done on a case-by-case basis. And of course, if you're seeing an athlete with HCM, that evaluation is pretty comprehensive and should typically be done by an HCM professional expert. So this is just a diagram that I think a lot of us have seen, which basically describes the dynamic and static components of exercise, and it's broken down into low, moderate, and high. So what about pregnancy and HCM? If anticoagulation is indicated in a pregnant patient, whether it's for atrial fibrillation or another indication, you can use low molecular weight heparin or vitamin K antagonists. It's important to keep in mind, this is not just for HCM, this is in general, that the dose of Coumadin should not be more than 5 milligrams. And most beta blockers, such as metoprolol, labetalol, propranolol, they're all safe. But tenolol is the one that's contraindicated. And vaginal delivery is recommended as the first choice delivery option. There's less bleeding risk, but if a C-section is recommended, or deemed appropriate for OB, then that's the way to go. In affected families with HCM, you do want to consider preconceptional, prenatal, reproductive, and genetic counseling, especially if they wish to pursue IVF, and pre-implant genetic testing, and then postnatal genetic testing. So if the patients are still symptomatic, you can consider cardioversion for new or recurrent AFib that's been deemed to be safe, especially for the fetus as well. And when our OB colleagues ask us, general epidural anesthesia are reasonable, the most important thing to keep in mind is to avoid hypotension in these patients because of drastic fluid shifts, especially since that would worsen the gradient and can cause these patients to become hemodynamically unstable. So just coming back to learning objectives, I hope I've gone, explained the pathophysiology of HCM, kind of explained how to perform appropriate risk stratification for sudden cardiac death in these patients, and gone over the pharmacological and invasive treatment options for management. In terms of, what the future is looking like, I think that there's some exciting research being done, especially target at the genetic and the molecular therapy level, because a lot of the initial pharmacologic therapies that we have, they provide symptomatic relief, but they don't really target the myofiber disarray. That's really the pathogenesis of these patients in HCM that leads to obstructive physiology. So hopefully targeting at the genetic and molecular level can help prevent the development of the HCM phenotype altogether. And we're also looking at the role of myosin inhibitors in non-obstructive HCM, as well as the role of SGLT2 inhibitors and mineralocorticoid receptor antagonists in these patients. And as I mentioned, the guidelines do recommend serially reclassifying these patients or retesting these patients for genetic variants since the database continues to evolve. And that's the end of my talk. Thank you for your attention.
Dr. Bhargav, thank you so much for this wonderful overview of hypertrophic cardiomyopathy. There is a lot from the guidelines that you have put in. It kind of talked a little bit about what we should do with future therapies as well. I'm going to start off with asking just a couple of questions. First of all, could you talk to us about the role of provocation to get provoked gradients to see how you manage these patients? The second question that I have is, what do you think about the newer agents such as aficamten? Because some of the more interesting thing that is coming out is the monitoring might not be needed, the echo monitoring might not be needed. So what are your thoughts on both of those questions?
Thank you, Dr. Magaldi. Those are great questions. In terms of provoked gradients, so the important thing just to keep in mind for these patients is that the LV outflow tract obstruction is so dynamic and so sensitive to preload, afterload, and contractility in these patients. So, even if they're asymptomatic, for us to, if they have a resting gradient that is less than or equal to 50, just to be able to see by Valsalva maneuvers, just a physiologic maneuver to provoke an obstructive physiology, can really help reclassify disease severity, identify patients, at risk for someone who might develop symptoms down the line, maybe progress to heart failure, and also really helps guide management, because if we know that they have obstructive physiology, you can potentially avoid maybe negative inotropic agents down the line. So it really just more so helps classify disease severity, give us an idea, and identify patients at higher risk for future events down the line. And in terms of the second question for aficamten, so I didn't really spend a lot of time talking about aficamten, but it seems to be a very promising drug. So it was actually engineered to really kind of optimize the pharmacodynamics, because mavacamten is great. It does have a couple of issues. So it has a long half-life. The mean half-life is about 8 to 9 days. It takes a couple of weeks to reach a steady state plasma level concentration, and also significant drug-drug interactions, with the CYP2C19, people 50 CYP2C19, drugs that also involve that pathway. So aficamten does not have those significant drug-to-drug interactions. It has a pretty short half-life. It's about, the mean is I think about 75 to 85 hours, and it has a rapid washout phase. You can actually titrate the doses every 2 weeks as compared to every 4 weeks for mavacamten. And so it has a wider therapeutic window and a shallow dose response relationship. So the trials that have been done, the one that I presented, as well as the Redwood, so it really does show that these patients had improvements in NYHA functional class. They had improvements in symptoms and a decrease in LVOT gradients. And there's actually more trials that are being done now. There's Maple HCM that's going to, which I think is exciting because it's going to compare metoprolol versus aficamten in patients with symptomatic obstructive HCM. And there's another trial that's going to be looking at aficamten in patients with non-obstructive HCM. So I think it's a very promising drug, and I think that we'll be getting some exciting results down the line.
So there are a couple of questions, actually. One from the chat. Dr. Chang, thank you for the extensive overview. At what age do you recommend initiating genetic screening in adolescents? This is truly a difficult question, right? So, yeah, what do you recommend?
Per my literature review, the guidelines really just, mention children and adolescents, but based on what I looked up, so typically you start at 12 years of age, and then you do annual screening. However, having said that, if they have a significant family history, so it's a malignant cause, sudden cardiac death at much earlier ages, then you can do it after 8 to 9 years of age. It's just that the issue with screening much earlier is, a lot of these younger patients end up with ICDs, and they have higher long-term complications. But yeah, typically it's 12 years of age.
One other thing is, the mavacamten is also being used in people who have non-obstructive HCM, thereby decreasing the number of hospital admissions for heart failure, which is extremely exciting. Do you think they're going to be more medications that we should be looking out for over the next many years? And I'm waiting to see when we get approval for this, for the diastolic heart failure patients, so HFpEF.
Yeah, and I think and the interesting thing about the myosin inhibitors that these are the first drugs that are actually working at the myofiber disarray level, which the beta blockers, calcium channel blockers, espermide don't really do. And so to see their role in non-obstructive HCM actually makes a lot of sense because they decrease the excess actin myosin complexes. So it's supposed to actually help with the impaired LV relaxation. So yeah, I think there should be more drugs coming out, hopefully, because again, aficamten was engineered just to kind of overcome, I guess, some of the issues they saw with mavacamten. So I'm sure based on the long-term data with aficamten, they can play with those, at the molecular level and come out with even more drugs that might have better pharmacodynamics.
Dr. Berger has a question. So Dr. Berger, please feel free.
Sure. Well, thank you. Thank you for this wonderful overview and review. Thank you. So I had a question. In a particular situation came up where somebody who had an older gentleman with coronary artery disease had, HCM with obstruction, and the MRI showed specifically scar in an area that was subtended by an occluded coronary. So you had about a 10 or 12% scar, and the question is, somebody who LVEF is normal. The question I had, and I had to go to the company for this, is can we use mavacamten in someone like that, who already has, some underlying heart disease that may be a higher risk of left ventricular dysfunction? So what would be your thoughts about that? And thank you.
Yeah, no, thank you, Dr. Berger. So that's a great question. I think one of the more important things though is the patient symptomatic, because we are not really using, again, the data that's been out there. It's shown that mavacamten improves symptoms and NYHA functional class in these patients and then decreases gradient. So in our clinics, we have not been using myosin inhibitors, even if the patient, let's say, has really high resting gradients or provoked gradients, but they're not symptomatic. So number one, I think that would be a bigger question. And also, if the patient is symptomatic, is it from that underlying CAD? Is it from the microvascular dysfunction that's playing a role? And can we optimize that medical therapy? So I think once all of that is optimized, and if the patient is still symptomatic, I think we actually could potentially consider it. And again, the good thing with mavacamten is they're getting periodic echoes, and it's monthly for the first 3 months, and then every 3 months from there on. So let's say even if they are at high risk for having systolic dysfunction in the future, the good news is this is reversible. It's completely reversible. So in our clinic as well, the patients who have had, systolic dysfunction, I think we had about 6 or 7 patients or so who had an EF that dropped to less than 50%. We discontinued mavacamten and we repeated their echoes, and they basically went back to their baseline LVEF. So I think that would still be worth trying after clarifying that they're symptomatic from obstructive HCM.
Well, that's great. Thank you. So I had him, for the record, I had him cath, and I do stress echo on patients with HCM. I find it very helpful. I also look at how much mitral regurg they get after I've obtained gradients, after peak stress. So yeah, I mean, he had, I don't know, 80 or 90 millimeter provocable gradient with stress, and he was class 2 to 3 in terms of his symptoms. So yeah. I mean, so
yeah, I think it'd be worth trying for sure.
Yeah, so that case, it turned out he also had multi-valve disease, so he's getting surgery with myomectomy. But before I realized, before the TEE demonstrated, MRAS, the question was, can I give this guy mavacamten? And since it's reversible, it sounds like I can in a similar case. Thank you for that. Appreciate it.
Yeah.
Do we have time for one more question?
Yes, absolutely.
During your pharmacology treatment or pharmacologic treatment during pregnancy, I think on the first bullet you mentioned anticoagulation. Do I have to assume that is reserved for the patients with atrial fibrillation? And the other question is, you also mentioned you recommend low, no heparin, of course, but the use of vitamin K inhibitors. I thought that those were teratogenic. Can you clarify me that statement in the slide?
Yeah. So basically, the anticoagulation, that was just I was just making a general point that if the patient requires anticoagulation, it wasn't necessarily in the setting of HCM. This is, if for any other indication, then the options in pregnancy that we do have are low molecular weight heparin and vitamin K antagonists per the recent data. And this is not just for HCM, for actually any other indication. The recent data has shown that if you use a dose of less than 5 milligrams daily, that actually has been safe, especially in the first trimester as well. So that is something that more patients are being placed on. But yeah, if not, then they can be on low molecular weight heparin, and then you switch to unfractionated heparin closer to delivery.
All right. So if you use less than 5 milligrams, will be maybe can be used, but
yeah, I mean, with
wouldn't be my first choice.
Making with the patient, but yes, it can be used less than 5 milligrams.
All right. Thank you. I enjoy your lecture.
Thank you.
So, Ruchika, this is absolutely phenomenal. I think we've been past the 6:30 mark already. So I'll ask the audience to send you any questions if they have any. Maybe they can email you or even leave a message. So thank you, everybody. And Ruchika, more importantly, thank you so much. This is fantastic.
Thank you, Dr. Magandhi. Thank you, everyone, for listening.